Hello and welcome. Hundreds of millions of Indians, students, school students, 250 million, hundreds of millions of workers, and of course billions of people around the world are asking one question: when will life become normal again post-COVID? Now, the answer, unfortunately, is only a little clearer now than perhaps what it was about a year and a half ago. But nevertheless, our understanding of the disease and what will effectively put it under control has definitely improved. So the larger questions are, how long will COVID-19 last in the way we know it today? Remember that in India, we've gone through a brutal second wave. Cases have come down now quite sharply across the country, except maybe in one state of Kerala where cases are high. But elsewhere, life with masks and other restrictions has come back to some kind of normal. Also, when we were to look, if we were to look at history to some extent, how does COVID-19 at its current stage, and to the extent that we can project, compare with other infectious diseases that we've seen in the past, including perhaps something like smallpox? Also, what is the combination of vaccine administration, lifestyle changes, which is the precautions that we take, and of course a cure, whichever way that it might come, effectively work to bring down the spread of this virus and of course take us back to life as we maybe knew it. So to answer all these questions, I'm joined by Dr. Monica Gandhi, an infectious diseases specialist and a professor of medicine at the University of California, San Francisco. She's also the director at the same institute's Gladstone Center of AIDS Research. Dr. Gandhi has a MD from the Harvard Medical School and a Master of Public Health from the University of California at Berkeley. Dr. Gandhi, thank you very much for joining us. So let me start with that very simple question first. What is the end game looking like for COVID-19 as we stand here at this point, which is also, let me qualify, end of September 2021?
Yes, it's a great question. You know, we have to look at history to understand what's happening with COVID. And to look at history of infectious diseases, we have to also remember our definitions of infectious diseases. So there are 4 levels of what we call containment. One is control. And control means that the virus has become endemic. It doesn't cause undue burden of death or suffering or healthcare systems being overburdened, but it's not gone. That is actually the end game, and that is the hope for COVID-19. Why can't we get to the other phases, which are called elimination, eradication, and extinction, where you actually, elimination means you take it away from a region, eradication means it's gone for the whole world, extinction means you even destroy lab stocks. The reason is it doesn't have those features that allow eradication. Those features means no animal reservoir, the COVID has one. Those features mean it's very clearly, there's like smallpox, it very clearly looks distinctive and not like other viruses. That's not what COVID is. COVID looks like a lot of respiratory infections. The third feature is it has a short period of infectiousness like smallpox had, which was eradicated. That's not what COVID is. And then the fourth feature is that you should be able to interrupt the chain of transmission. Unfortunately, because people can still pass it on before they have symptoms with COVID, it's going to be impossible to eradicate it. Lucky thing is going down to endemic, low rates of circulating virus, having it in control, which means that it doesn't cause undue burden. That's the end game for COVID, and we are getting there in many places.
Right, and you know, you compared this in an article you wrote recently for the Washington Post with measles, or at least contrasted it with measles, where you may see sudden outbreaks which can be quite big, but in itself do not mean that everyone else is going to be affected. Is that a fair comparison?
Yes, the best comparison is either with measles or even pertussis, which is a bacterial infection that causes whooping cough. And both of these infections, over the world at least, are in control. You can absolutely see outbreaks. Those outbreaks are more among unvaccinated eligible people. You may even see mild disease in people who have been vaccinated, but you know how to treat it. And we do have treatments for COVID-19. So it doesn't mean it's gone worldwide. Measles and pertussis are not gone worldwide, but they're at low levels and they're under control. And that is what we're hoping for COVID. And you can see places that are getting under control. You know, there are places that are wide open and they're saying they're done with COVID. That's Denmark. at 74% vaccination rate. That's Norway, who opened over the weekend at 67% vaccination rate. And we can talk about India and the US because they're very different circumstances.
Right. And how are you seeing India at this point of time before I come back to the measles question?
Yes. So India is an interesting example of we are not there yet, but getting to what we call control. And or endemicity is the other word. Endemic means low grade circulating virus, but doesn't cause undue burden on the healthcare system. Why is India getting there? Very sadly, it's actually what you just said. There was a terrible second wave, and there was a lot of death, a lot of suffering. That actually led to natural immunity in the population. And at the same time, India very quickly started vaccinating very strongly during their second wave. So there was a lot of increase in vaccinations. You combine vaccination-induced immunity, natural immunity, again, the population becoming immune. Before vaccines, remember, that's the only way to get through a pandemic. Measles, pertussis, smallpox, influenza A. Unfortunately, before vaccinations, the only way to get through it was people getting naturally immune. But in India, there's natural immunity, there's vaccination-induced immunity, and the cases are coming down, and they are lower, except in Kerala, like you just said.
Right. So to come back to the example of measles now, obviously COVID-19, as we know it, is a deadly disease, maybe deadlier than other diseases. Though I'd ask you to illustrate that for us. Now, would it be correct to say that, like measles, you could see an outbreak, let's say 12 months later or 18 months later, and that would be as deadly, as virulent as it is today, except that it may not happen in most places, or it may happen in very small pockets. So in a sense, we cannot forget what this disease was like and the harm it could do.
Yes, this disease can do great harm. The thing about measles is it also could do great harm. So measles was first identified in the 9th century, and we actually didn't get a vaccination for measles until 1963. So remember, the way that measles was controlled prior to mass vaccination is that people would be born, they'd be non-immune to measles. They'd unfortunately have to get measles to become immune, and that immunity was lifelong. In fact, we actually don't vaccinate people who are born before 1963 because we assume they've had measles. So there are differences with COVID-19. COVID-19 is more deadly, but we also have better treatments than we've ever had for measles. We actually have true treatments now, monoclonal antibodies, remdesivir, steroids. There's a antiviral coming out named molnupiravir that we have great hope for. The results are going to be released this week. So hopefully we'll be able to treat more mild cases. And the question of lifelong immunity is still a debate, but there are good features of immunologic research that show long T cells, long B cells that we hope will get lifelong immunity to COVID-19. So there's a lot of hope that it can become like measles. And if you think about measles, you don't actually think about measles very much in the general population. We think about it as I'm an infectious disease doctor. I think about it, but it is gone from the public view, but it's absolutely still a problem. It's not gone. It's called under control, and that's the hope for COVID.
Right, and you talked about T cells. Could you walk us through what that means, and also in the larger context of vaccine efficacy as we know it at this point?
Yes. So it's just to put it very simply, there are two arms of the immune system. There are B cells and there are T cells. And the B cells are the one that produce antibodies, but those antibodies are going to come down with time. Totally natural, not a glitch of the immune system. You can't keep all those antibodies in your bloodstream. Your blood would be too thick. So they're going to go down with time. But memory B cells are blueprints to make more antibodies if they see the virus again. T cells not only aid B cells making more antibodies, but T cells, which are very long lasting, prevent severe disease. They basically protect you from severe disease. So what we have seen from immunology research with these vaccines, also with natural infection, is that T cells look like they're durable and they have what's called a very long half-life, meaning they just look like they're going like this and they don't look like they're coming down even when people were infected. Now we have 20 months of data. And so they do look like they're going to be durable. And we know that T cell immunity is durable. People have had their measles vaccines 40 years ago, still have strong T cell immunity. People who had SARS in 2002, 2003, but recovered, still have strong T cell immunity 17 years ago. If this protects us from severe disease and T cell immunity is long lasting, the hope is we will get long lasting protection from the vaccinations or from natural infection for a long time.
Right. Therefore, where do you stand on the booster debate?
I think that in the United States, I did actually stand on the fact that I think older people, immunocompromised people, should get a third shot. Why? Because those are always the populations that we're not sure they form the strong B cell and T cell immunity, and those are the two arms of the immune system that you need high to get vaccinated, to get long-lasting immunity. So I approved the immunocompromised, those over 65. However, giving widely third booster shots to everyone, the data did not indicate that. And so by the way, here in the United States, I would definitely talk to your doctor before you decide on a third shot. If you're younger and healthier, I really just would have that conversation, and I would approve it for older 65, which is what I'm recommending to my patients.
Right. So tell us about the evolution of COVID-19, again, something that you've written about. So what could we see happening to this virus as time passes? Is it going to become stronger? Is it going to become weaker? Is it going to be exactly as it was, to again use the measles example? And what can we learn from history or from other infectious diseases, if we can, in this context?
It's a great question, because the only thing we can look to is history. So one thing to remember about measles and pertussis and all of these infections is that they have never evolved to become more virulent. In fact, let's just remember that every pandemic, except for HIV, malaria, tuberculosis, where we don't have an effective vaccine, and also HIV, of course, infects the immune system, every one of these respiratory virus pandemics have ended because of immunity. They haven't kept on going and becoming more and more virulent. And importantly, we've never changed the measles vaccine. We have the same vaccine in 1963 that we use in 2021. So why do viruses not evolve to become more virulent and keep on going and going and going and going? Because when a virus evolves, and this is sort of evolutionary biology, it usually takes a hit in some other function if it wants to gain function in one way. So what is the Delta variant, for example? The Delta variant has gained the ability to be very transmissible. It transmits very readily. It's very quick to go from person to person. But it hasn't clearly shown that made it vaccine evasive or in some way more deadly. We just had a lot more cases because Delta is so transmissible. This is true of HIV itself. It can evolve to evade the HIV drugs that we use, but it takes a hit to do so. It becomes less fit. So history will tell us we have never seen a virus that keeps on going and going and going. Because remember, measles was identified in the 9th century. We don't see worse and worse measles now.
Right, and that's encouraging to note. So a few words from you on HIV, and can we draw inspiration from where HIV is or isn't today?
Yes, it's a great question, because HIV, which was first described in 1981, but probably entered human populations around the turn of the 20th century, has not evolved in any way to become more virulent. In fact, once we got good HIV medications, which, by the way, the best ones were formed in 1996, and they've just gotten better from there, the virus actually becomes less fit if it evolves to evade the antivirals. Though HIV is still clearly a problem, we don't have a vaccine against HIV, it is controllable. Why is it controllable? Because we have antiviral medications that shut down viral replication, and it keeps it a chronic lifelong disease. So when we think about COVID-19, we are in the 21st century. We are developing treatments that hopefully are going to be targeted just against COVID-19. For example, molnupiravir is this antiviral. The data will be presented just this Wednesday at ID Week, which is the phase 3 data, which is a big meeting here being held in a couple of days. If molnupiravir looks good, you can imagine a world in which someone comes in, they have a moderate respiratory infection, they get swabbed, it's influenza, they get Tamiflu and oseltamivir, and and it's COVID-19 and they have moderate disease, they get molnupiravir and they go home. And if they have mild infection, because that's what COVID-19 should do, is bring down severe disease into a very mild infection, then they go home, they have a cold. So this is the dream and the hope for what the vaccines have done for COVID.
Right. And if you were to now look around the world, the fact that, we are still vaccinated in some parts and better control in some parts of the world and not in other parts, how is this likely to affect the transition or the trajectory of this virus as you see it, particularly in the next year or so?
So when I look around the world, there are places, again, who have 2.2% vaccination rate. I mean, the doses of vaccine that we have given out in sub-Saharan Africa, for example, only 2% of low-income nations have gotten our vaccine supply. So it really is, I think, tragic in terms of our global vaccine equity. But there is a combination in other places like India of natural immunity and vaccination-induced immunity. And then a place like Denmark and Norway are more vaccine-induced immunity because they had high levels of access and they had high levels of uptake of the vaccines. At all levels, it's getting to the same point. It's immunity. It's immunity to the virus. And you want immunity, of course, through safe ways like vaccination, but ultimately they'll all get to the same place, which is endemicity, low levels of virus that we can manage, it's under control, and we can live with it.
Right. Dr. Gandhi, last question. So what are you working on specifically right now in as much as your understanding of where you see this disease going in coming maybe months or a year, and also your points of optimism and maybe concern?
My points of optimism are that when I look at history as an infectious disease scholar, I think, because I'm interested in infectious disease, the optimism is it will end. It will not end exactly the way we want it. It won't be eradicated from the face of the earth, but it will end. It'll be controllable, and we will go back to normal life. I really do believe that. And again, two countries and many countries in this world, actually about 4, are completely wide open back to normal life with high rates of immunity. So it does happen. This will happen. However, I think that what happened in this pandemic, we have to learn about what we did as a world, that we had vaccines since December 2020. India, for example, appealed to the World Trade Organization in October 2020, asking for vaccine access for waiving of patents, and they were denied. And then March of 2021, this terrible second wave happened in India. I think if we do not learn through this epidemic through this pandemic, that we are one world and that we have to give vaccines out to the whole world, we could have this happen again. So that's what I'm working on and interested in. And then fundamentally, even with mild disease, it's important to remember that we will have antivirals to work against mild disease. And I'm also interested in that.
Right. Dr. Gandhi, thank you so much for speaking with me, and I do hope to connect with you again.
Thank you very much.